Assalamu alaikum ji. So now we go to a different way of talking. We talk with each other. ठीक है ना? बहुत हो गई सुनने की खड़े होके. यार इसको प्ले भी कर दो और 30 मिनट का है मेरा सेशन. याद रखना. उधर पंगा ना लेना क्योंकि इन सब ने बोलना है और मैंने सुनना है. So the step one, my disclosure. So this is industrial sponsored. There is no conflict of interest. I have taken assistance in developing these presentations. Even my trip is not sponsored by the industry who has asked to do this talk. Acha, hota kya? What are we up against? These are the patients that I usually see. I see that Dr. Tahir Naveed is also sitting, who said that I'm not coming, but anyway, nice to see him over here. So a 48-year-old male, all these patients come in to your hospitals and the answers are very clear usually. STs are rising, chest is painful, STs are not rising, drops are rising, and you take them into your cath labs. But then there are other patients who are also coming. And you have these patients. A 65-year-old diabetic presented with shortness of breath on exertion, history of ischemic heart disease. Her cardiac evaluation was done, which showed troponin normal, ECG non-specific, echocardiography with mild LV dysfunction. May I have the panel start off the discussion? What is your next step? Name sir. Whichever name.
Hello. जी, तो उसके बाद what we will do next? We will go for labs, we'll do for electrolytes, RFT, and one of the most important tests that is basically important, you have to differentiate between whether patient is having purely heart failure and 65-year-old female. Mostly these patients presents with superadded chest infection, community-acquired pneumonia, oblique heart failure.
So for you, the next step of
next step we will
basic blood tests.
Yeah, basic blood test.
Harun Saab, your next step is also basic blood tests, or you like to do something different?
X-ray chest.
Let me see the first slide.
इसे कहते हैं कि स्पीकर तो बोली जा रही थी पैनलिस्ट कितने और पहुंचे हैं सर यार वापस लाओ स्लाइड लगाओ यार with the cap नहीं वो कैप वाली बाद में आएगी अभी ये वाली आएगी so this is your patient and your next step so he goes to clinical examination. The point that I wanted to thank you, we have got an answer. So the point I'm trying to say is that we don't all agree what the next step is. We always have a set of difference of opinions. So what about this patient? हमारे यहाँ गैस ने बहुत तंग किया है. You know, everyone has gas over here. We are short of gas, yet everyone carries gas. So electrophysiology is intake, sir. General sir, Bilal sir, आपका intake, sir. What do you think is the next step over here? A detailed history. Our presenters. Haji sir. So creatinine levels, etc. So everyone has an idea of what to go ahead. And now what I'm going to push forward is that this is what a lot of us do many a times. We do our troponin levels despite everything, and there are people who will be saying that I want a serial analysis to be done. This is the data for about 2 weeks from my hospital. And a few of us also opted for pro-BNP, and we found a serial of issues in the pro-BNP also of these patients. These are that subset of patients in whom the diagnosis of the initial management was not clear and they were not going to cath lab. So there are biochemical markers that you can look at, and now we go into those biochemical markers and we start talking about them. The NT-proBNP, the heart failure. आज सारे हम लोग heart failure की discussions करते रहे हैं, so let's focus on the basic biomarkers that we are also doing. So class 1 recommendation includes NP as initial diagnostic test. Now the question is that is this really our class 1 investigation going on at the moment or not? By and large, because of its cost, because of its availability, it is not your class 1. It's not like a test which is done immediately when the patient walks in. You always actually end up waiting for it. Of course, NT-proBNP can be elevated because of other reasons also. These are the cutoff markers of 125. Age is the place from where we start looking at it. The reality is that if you keep NT-proBNP as 125, you'll be able to pick up more people. If you take your NT-proBNPs as higher, which is with age many a times, you may start losing your patients. These are the various cutoff trials which were there, and they all showed the same factor. So, NT-proBNP is useful for diagnosis and strongly predicting short-term mortality in acute heart failure. This is what everyone has been talking about previously over here. How many of you agree with it? How many of you actually tell your patients that your pro-BNP takes you closer to your last day? How many of us actually, sir, how many of us do these programs? It has, how many of us communicate it to the patients? The reason why I'm saying is that then you cannot,
underused test है.
then we do not push to the 5 pillars quickly. Farooq? What?
Actually, in heart failure, now you have multiple modalities of assessment in terms of patient status, especially clinical. Clinical status can be judged with your examination, with your history. So this is an additive, objective evidence to that. So a number of time, like 70-80% of the time, your clinical judgment helps you a lot to decide, especially when you have patient at spectrums. Frank failure, do you need for diagnosis NT-proBNP? Certainly an objective evidence will help, but a frank failure you don't need at that moment. You need it for that of levels and then subsequent follow-up regarding titration of medication. You need it certainly in those cases which are borderline and overlap with other differentials. There this test is needed obligatory in a way to decide which one is dominant. Is it the heart failure or the pulmonary component? So it has utility, but it's not that kind of thing that done in 100% of the patient all the time. That's my take on that.
Well, no doubt what our friend has said, but it is the most underused test in the sense of prognostic evaluation. Because I think we are not at the level, we have not reached the level of prognosis at the moment. We just simply treat the cardiac failure patients and send them home. This is what is going on at the moment in our country. The thing is, you have to, when you have a patient with cardiac failure, like you earlier said, you have to treat it as a whole. You don't have to only get rid of the symptoms and send the patient home. So for prognostic purpose, test is of great value.
Professor Kashif?
In terms of that, after that I was just talking about diagnosis. Then subsequent treatment, titration and management strategies, very helpful, because we are discharging patient prematurely. When you're discharging on like after 24 hours because of the patient load we have, that NT-proBNP at that point in time will tell you that certainly you have get rid of symptom, but the filling pressures are still very high. You need to really rearrange your management strategy according to that.
My question remains, again repeat the same question for Professor Kashif. So, do you think that when they say that NT-proBNP is a prognostic marker, should be done and should be discussed with the patient, do we do it?
जैसे बाकी पहले बात हुई है कि अंडर यूज टेस्ट हैं फॉर प्रोग्नोसिस शुड बी डन, उस बाद ने बात की कि जो ना एट मेनी टाइम्स वी डोंट नीड एक्चुअली कि हमें डायग्नोसिस में इसकी ज़रूरत नहीं होती, बट फॉर प्रोग्नोसिस एंड फॉलो अप एंड टू फॉलो द पेशेंट एंड टू प्रिवेंट द री एडमिशंस वी नीड इट.
Chale, I'll move forward. Next slide coming up. Sir, mic क्या इधर सर को देना यार? Bring a mic forward. Sir, we many a times, all of us, hide behind the garb of expense. On one side, we are talking of a test which costs a few thousand rupees, and I know how to fight with, Ahmed Badesha is sitting over here, we know how to fight with prices, and we can really get these prices slashed down. The trick is, the first question is, that do we all agree that this is a fundamental basic test what the international community today is advising?
Dr. Bilal, this is a forum of for scientific purposes. I don't think we should bring in the cost issue here.
Yeah, I agree.
That is another issue.
Well,
So you have to talk with scientific evidence.
so, heart failure prognosis and clinical course. या इधर माइक लिया कोई अल्लाह के बंदे?
If we can detect heart failure early stage, I think that's the best utility of this test.
Because many times, actually, exactly what you have said is that patients come in with a shortness of breath, some failure, etc., and they're not properly labeled as heart failure. You put a probe on the echo machine, and you'll see a reasonable LV function, and you won't be seeing any MRs. You say, okay, go.
We only say heart failure when patient comes with edema
And EF is down to 25%.
and JP is raised, then we are concerned. See. So I think the best thing is to diagnose heart failure before it is clinically manifest.
Yes, it is. Yes, I agree.
So let's move to the next slide, and we have some more discussion. Okay, slides over here. So now we are talking of this. This is the reality matter. Patients come in, and you look at all what is happening with them. So mortality rates of chronic heart failure is 50%. Long ago, when I remember one of those older books, and it said 100% mortality at 5 years. Now, thank you, it has come down, and hopefully with the newer therapies, drug, lifestyle, early detections, it will come down further. But these are the facts that you can see over there, that if you are able to pick it up early, you can make a difference. This is the issue. There are problems which are going on, and we are not focusing on them. That this is going to lead to the heart failure. So placing heart failure in the context of other medical conditions such as ASVD may make the extreme high risk and very extreme high risk more readily apparent. We are not making things apparent to ourselves, and neither are we making things apparent to the patient. A patient will only understand if you take a matter into its full throttle. How many times do we actually spend 5 minutes trying to convince them to quit smoking? The simple statement is, cigarette mat piyo. Do not smoke, it causes harm. A lot of our fellows even don't know that the carbon monoxide issues that the cigarettes create. So these are the places where we need to sort of start once again focusing on. This is the problem, the clinical risk and everything. So while you are still in the green phase, if you are able to pick up your patients early in the green phase, as such, he's going up in the risk. This is the place where the preventive cardiology steps in. Today, earlier, we had Professor Wajid from Punjab Cardiology talking about prevention and etc. And that is exactly what we are trying to go down to the community. In our own hospitals, those with heart failure, those with problems, we get their families in, and we are trying to screen them, teach them the issues, how to manage their life. These slides you're all very familiar with, that how things go up and down. Undiagnosed underlying cardiac functions, and all of these things, and then finally the doom when the RV starts failing and you have those swollen legs, and this is the stage when you start telling your patients that you are actually in heart failure, while he had been warning you many, many years before that this is what I'm going to progress to. Things which bring these patients back to us, and the things that we least sort of focus on. Does he have an infection? Unfortunately, a lot of ladies carry low-grade UTIs with them. A lot of people carry throat infections in our country. They've got upper respiratory tract infections, and we are not focusing on all of them. Kidney worsening, arrhythmias, this we look at. But it is that bloody infection which, when he comes in, he's going to be resistant to so many antibiotics, and he is going to occupy your bed for not 1 day, not 2 days, but at least for 2 weeks. And that is where the problem is. Now, do you agree with this slide? Everyone has been talking about it. General Samor, do you agree with this slide? Everyone has been talking about this, that despite substantial rehospitalization, I'm going to make sure that you're all listening to me, not talking with each other. So, do you agree with this slide? Mic for General Samor, please, over here. Sir.
Yeah, we've got some exemptions.
अरे सर आज तो हार्ट फेलियर का हमने तिया पांचा करके ही निकलना है. वो हमारा हाजी भी होके आ गया, हज पे दुआएं करता रहा कि सर मैनू किस वाले में फंसा देता है. So, हाँ जी, हार्ट फेलियर के इशू. So, यार वो स्लाइड वापस लगा दे, ओ हीरो बाद में. हाँ. So, do you agree with this thing?
Fully agreed.
Fully agreed. So, when we agree with something like this and we are not fighting about it, that actually shows something about us, and we need to do something about that. This, of course, is how the thing happens, and this is the days that I was talking about. Notice that your first admission takes up at least anything between 6.5, 7 days to 7.5, 8 days inside the hospital. That's what the West says. Our patients usually come in later, and yet we are throwing them out very rapidly. Yes, I understand we have our resource constraints, but we can always explain to them how to convert their home into a hospital also and go forward from there. How to keep coming back and encourage our hospital administration to have heart failure clinics, dedicated heart failure clinics where these things are done, where a very basic investigation is the body weight going up or not? Heart rate is staying stable or not? Because if you are not going to have these very basics sorted out, your NT-proBNP, your troponin Is, your sodium, your potassiums are of absolutely no value. So the treatment of heart failure, as we have discussed all these pillars and even 6 and 7 pillars, and probably somewhere down the line someone is going to come and say that even the statins and other things are also one of the pillar because they also make a difference as far as everything else is concerned. But the fact about ARNI that I would like to really point out over here with my colleagues is, how many of you are witness to the fact of a person receiving ARNI 50 milligrams, half a tablet once a day? I am. 50 milligrams, half a tablet once a day.
Well, it is recommended that you should not divide the tablet in the
Perfectly
original.
great. So again, things which are not recommended are being done by our colleagues. So we need to reach out and explain that this is not recommended because the tablet is not a divisible tablet. You don't really know, it's not a mixed up medicine. So we have to be careful about that. Sir.
Actually, in some of the formulations, the tablet is scored. That is number one. And the other thing is that I discussed it with the people in the ESC. They also, even if it is not scored, they can reduce it to half a tablet. And the reason for that is that these are the patients who have low blood pressure, but they are not symptomatic. They are asymptomatic. And they think that in such a case, the benefit of ARNI should be given to these patients despite the fact that their blood pressure is low.
So sir, I will get in over here further and I'll let you know the industry figures. The industry today is saying, the industry figure says that nearly 70% of the market, 70 to 80% of the ARNI market is with 50 milligrams. 15 to 20% is with the 100 milligrams. And only 1 or 2% are prescribing 200 milligrams. Thus, you see a lot of your prescriptions of 200 milligrams bouncing.
If you look at the titration trial, there actually you have 50 milligram, 100 milligram twice a day, and 200 milligram twice a day.
And it's twice a day. But you see, the tablet has to be medicine.
And
It's the same problem. It's the same problem that we have even with statins.
the reason
The 40 milligram rosuvastatin or the 80 milligram atorvastatin is not available in our market simply because people, though, would be talking about it, but would not be prescribing it.
40 milligram statin actually is not, even in the Far East, they don't use it because it has an adverse effect.
So we are not Far East, we are Southeast Asia over here, and our generations and our genetics is more towards the to the Central Asian population, because that is where from a lot of our
What we
forefathers did come. That's why our physiques is tall and bigger.
What we can do is that we combine 20 milligram of rosuvastatin with 10 milligram of ezetimibe, and that will become 40 milligram.
Perfect. So, okay, slides please. So this is what we are, that things are happening, but again, the higher dosages now coming up are plenty more, and it is because of this reason that many of our lipids and LDLs are not reaching the 70 milligram target that is actually recommended. So these are the things, of course, that you already know, and a lot of has been discussed, so I won't go into these things in more detail. There's something better to be discussed, and it is this one. That if you prescribe these medicines, each medicine has a mortality benefit. So you need to give these medicines and make sure that every medicine's individual mortality benefits are common. But this is the problem where you see 25% eligible patients receive triple. Only 1% are actually receiving full dosage of all medicines. Now these are the problems that these meetings are supposed to highlight. Sir, you agree? You have been a director of the hospitals, etc. So what is the reason? Why do you think the hospitals are not focusing on it? Mike, sir.
There are basically two, three main things. Once, basically, why we are not at guideline, because patients are mostly not tolerant to the full dose what is recommended in the guideline. And if secondary guidelines are just to guide us, they are not just to dictate us. We can have our own clinical experience, what is in our local
Sir,
population.
the guideline says maximum patient tolerated dose. It
Yes.
does not say that you have to go to 200. It says maximum
Yes.
tolerated. It says beta blockers, guided beta blockers keep the heart rate above 55. You don't have to go to full 50 milligrams. So my point is that patients are not receiving, you still have patients who are being on treatment for a couple of months and years. Their heart rate persistently is in the 90s, yet their medication is not going up.
Actually, this happens with all those who can tolerate. Yes, you have to up titrate. But most of the heart failure patients have other comorbidities. Sometimes they don't have that much pressures, sometimes issues with rhythm, sometimes CKD, potassium. So you can't give all 4 medications at maximum doses to every patient. You have to decide tailor-made according to the comorbidities. But I agree with you that those who can tolerate should be on their maximum dosages, and this up titration should be as early as possible, within 4 to 6 weeks of NEV patient, to get all 4 medication at maximum possible tolerated dosages.
There are recent study, recently published last year, Intraspire study that was on secondary prevention on the guideline mentioned or guideline recommended therapy. And it was in 14 countries, 4,500 patients. And that have shown that more than 60% of the patients, they were not at the target level what is recommended in the guideline.
Slides, please.
Dr.
Slides.
Bilal, it's very important to mention here, this is a very good topic you have taken up about the dosage of drugs and which drug to start first. And I think it should be with the compelling indication. Whatever the compelling indication is in that patient with heart failure, that drug should be introduced first.
I totally agree with
Number
you. So
one. Number two, all these drugs, the pillars which we call 4 or 5 or 6, if they are introduced with a smaller dose, they have a synergistic effect. Rather than you increasing the dose of one drug to the maximum, and waiting and then introducing another drug, it doesn't look
Yes,
very logical.
the rule now
So
currently
you
is
have to
that you-
introduce these drugs one by one,
one,
and they should act synergistically with the least possible dose where the patient can tolerate.
Perfectly
and
correct.
then you can build all of the 4 up one by one.
So basically taking up. So General Suhail Sahab, the slide over here for you and your opinion about this patients. This is what they say is the problem. Mic for General Suhail, please. Mic for General Suhail. So we have these proportions of eligible patients not receiving medication. You are currently heading a hospital, the cardiology department, you have been heading a FIC. These are the problems, and they say that ARNI is not prescribed in 88% of patients, despite the fact that the systolic blood pressure is reasonable.
Thank you for asking me to make comments. This slide is very important, but more important is what's just been discussed here. Okay, how to start this in people with heart failure. So the concept is that jitne pillars all are started at a lower dosage and then followed up to how they respond. Agar benda take uska heart failure hai, you can increase on the diuretic. अगर बीपी मेंटेन हो रहा है तो आप उसके एंटी हाइपरटेंसिव्स को लेके जाएं, पोटेशियम खराब हो रहा है तो उसको केटर फॉर करेंगे, बट यू मस्ट ऐड एज मच ऑफ दीज पिलर्स एज पॉसिबल एंड देन बिल्ड
it up from there.
हर
So,
प्रैक्टिस % चेंज.
so for that we move back to the slides and we talk
एंड आपने
about.
मुझे जो माइक दिया है, मैं आई टेक दिस एज अ डिलिबरेट एक्ट ऑफ.
सर वो आप एक किताब पढ़ रहे थे बड़े ध्यान से, वो फिनेरॉन के ऊपर, और मैंने कहा इस फिनेरॉन की किताब में बहुत कुछ लिखा हुआ है, आपसे बाद में पढ़ेंगे इसके बारे में. So slides please. So acute heart failure management and pre-discharge planning. So everyone, this is the way they say that you need to start managing your patients. So you have to look at the fact that patients in hospital tend to do better than patients when they go to home. Patients, all these medicines that you know are recommended. Everything has a class of recommendations which is 2A or higher. And congestion of significant proportion of patients with acute heart failure are discharged with persistent congestion, which is associated with the higher risk of readmission and mortality. This is where the problem lies. We are in a hurry to have them go, and that is where we are making a mistake. We need to have our administrations, of course myself included, to do something about it, which is going to be an uphill task, but a task has to be started, and that is how we make things better. Everyone has talked so many times that these medicines are not being prescribed in the full dosage that they should be, and this is where we have the problem. I'm rushing through the slides now because I know you have had enough of me. And the characteristics, patients, this of course you all know is the contemporary definitions, etc. Those of you who are interested, they can later on get these slides from the organizers. Dyspnea, etc. is there, and post-discharge management of heart failure, which actually requires that these patients must come in frequently and be monitored. This is the last slide, and I'll end it over here, because if your NT-proBNP is done at the base level, and then if you are able to demonstrate that your treatment has made a difference for the better, you can actually tell your patient and give them a reason. On the other hand, if it is going down, it is a reason for you to become more aggressive. And that is what is needed today. We must focus on a treatment plan. We must focus on how to go about doing the correct, needful, scientific fashion so that our elders are properly looked after. And with that, I will say thank you, and all the ones who are interested in more slides can have this one later on from the organizers. Thank you.